Welcome, everyone. This is the 10th session of the OESO-SEMPIRE Virtual Educational Channel. This session will be managed by Dr. Luigi Bonavina from Milan. Today we have more than 100 participants who has registered in about 30 countries, and I will hand it over to Robert for the introduction. Robert, the floor is yours.
Thank you, Frederick. A few words, and I am pleased to say that it was May 28 last year, 2020, almost exactly 1 year ago. And innovating, as usual, the OESO-SEMPIRE platform of excellence in esophagology offered to the international community the response to the dreadful pandemic to remain true to its mission of education. This was last year, May 28, 2020. Our response was from the outset the development of a program of clinical case discussions offered on a regular basis by one of the pilot centers that constitute our network of excellence in the 5 parts of the world. The list of the 9 countries having already organized a discussion of a clinical case since May 28 are here. You can see them here. And today is the anniversary. And last year, as today, it was Milan that inaugurated our new formula with Professor Luigi Bonavina. You can show him, Frederick, at this time. He was, yes. And I think he was young, very young at this time. And he already was the main actor of the pilot center. And he is, in addition, the regional officer for Europe of the advisory board of the OESO-SEMPIRE platform. Presenting at this time a long history of GERD in a patient with a giant hiatal hernia, Professor Bonavina inaugurated this series of virtual, global, interactive staff meetings around a clinical case wisely chosen to constantly maintain the interest of the virtual audience. At that time, over 150 connections from 40 countries registered for this very first broadcast. I must say that the impeccable organization carried out by the president of the OESO Foundation, Frederick Julie, allowed from the smooth running of the very well prepared and perfectly presented clinical case by the team of the Pilot Center of Milan. And this was a challenge at this time when it was the first attempt that we made together. And this is the same time, the same team, which is going to present the 10th case to you today. There is Professor Bonavina. Today, again, here he is, with Emmanuel Asti, the coordinator of the Pilot Center, Stefano Siboni, the director of the Esophageal Physiology Laboratory, and we're pleased to welcome here Pamela Milito from the Milan staff as well. They have chosen a particularly educational clinical case, which will give rise to rich and instructive multidisciplinary discussion, I am sure, for which an impressive panel has been put together, including Professor Yangling Chao, Professor of Gastrology in Guangzhou, and Vice President of the Chinese Society of Motility in China. And we're very pleased to welcome her today as well. And we spoke about her participation in the network of our pilot centers in the very near future after the summer holidays. Prakash Gyawali, world expert in his field, with Roberto Penaggini, are hopefully also contributing very strongly to the discussion, as well as John Clark. John Clark, very familiar of our discussion of the clinical cases discussion, and he is the president-elect of our organization. Finally, Robert Bechara, he is from Kingston, and he is a recognized specialist in surgical endoscopy. Well, what shall I say? Today is the anniversary of the first clinical case discussion. It is a great day for us because we are going to meet our challenge, I think. And today, another exciting case, another fierce discussion, which is almost on course, and perhaps, I hope, a controversy over the best therapeutic strategy to adopt for this patient. I turn it over to Luigi.
Thank you, Robert. Thank you for inviting me again to this interesting multidisciplinary platform. And today we'll be discussing, I hope, an interesting case of it's an esophageal motor disorder, and as everybody knows, esophageal motor disorders indeed continue to be attractive both for GI and surgeons. And we live now in an era where high-resolution manometry has been a really revolutionary tool and has led to a rethinking and a reclassification of some of those esophageal motor disorders. And as in many clinical scenarios, HRM has also introduced some doubts, some interpretation problems. And well, that's way, it's not by chance that we have now reached the 4th version of the Chicago classification. And among those esophageal motor disorders, there is no question that spastic disorders have attracted our attention for many years. And looking at my old picture that Professor Julie just showed, that was a picture I took at the University of Chicago back in 1983 when I first was a fellow of Dr. Tom DeMeester and the late Professor David Skinner. So spastic disorders are still an unsolved clinical problem. And I remember the time when Professor Van Trappen from Europe, Professor DeMeester, and many other giants of esophagology discuss about the overlap of those motility disorders, and they were also discussing about the natural history of some motility disorders toward the classic decompensated achalasia. Today we have new tools and we have new acquisitions in pathophysiology, so hopefully we'll be able to clarify our clinical case. I'm pleased to invite to this case presentation Stefano. Stefano is the chief of pathophysiology unit in my department, is the Department of General and Thoracic Surgery. And Stefano, I think he will do a nice job. And Pamela is our chief resident this year. She's an incredible girl. She's an incredible physician. I must say, she's also an incredible surgeon. So let's start. And Stefano, please go ahead with your introduction and the presentation of your clinical case.
Thank you very much, Professor Bonavina. Thank you, Professor Jolie, for the opportunity to present this case. So we're discussing now. I will share my screen. Here we are. So I will start this case with a brief introduction on hypermotility disorders. As you can see here, and as you all know, hypercontractile disorders are major disorders of peristalsis, and the main clinical entities are distal esophageal spasm and jackhammer esophagus. In particular, jackhammer esophagus is defined as, at the manometry test, as more than 20 swallows with DCI more than 8,000, which is the threshold for hypercontractile swallow. But there is also an heterogeneous pattern. So we will discuss and we can define the jackhammer esophagus as LES dependent or independent, and single versus multiple peak. Take into your mind this distinction, because there will be a topic on the panel discussion on this point. Pathogenesis is largely unclear, but we know something. So for the first recognized cause of edge junction outflow obstruction is, of course, of jackhammer esophagus, sorry, is edge junction outflow obstruction. So it can happen with peptide stricture, with fundoplication, with bariatric surgery. As you can see here, this plot of HRM shows an hypercontractility after Nissen fundoplication. The second recognized cause of jackhammer esophagus, it might be a muscle layer hypertrophy, as you can see in this study, where the group of Mittal showed that there was a thickening of the muscle layer of the esophageal wall in achalasia, DES, and hypercontractile esophagus. The third cause is neurogenic, so there might be a neurogenic pathway that we can correct, maybe we can correct with medical therapy. And of course, we have a correlation with eosinophilic esophagitis. There are several case reports in the literature that shows a significant association between these two diseases. And the regression of the jackhammer esophagus after corticosteroids therapy given to cure the eosinophilic esophagitis. And then, of course, a big chapter will be the opioids therapy. So this want just to be a brief introduction, just to enter in the topic. So I will hand it over to Professor Bonavina again, that will lead the discussion, the panel discussion between our fantastic panel.
Thank you. Thank you, Stefano. At this point, we would like to encourage you, the panel, to discuss some specific topics. And we ask now Professor Xiao, she could tell us about phenotypes of jackhammer esophagus, and does it make any difference for treatment?
Okay, thank you. Actually, when we talk about the classification of Chicago 4.0, actually, we no longer divide the esophageal disorder into the major and minor one. We only divide it into the EGJ disorder and the esophageal body peristalsis disorders. So actually, hypercontractile esophagus is in the classification of the peristalsis disorders. And in this version, we use the hypercontractile esophagus because in this classification, we have three phenotypes of Jehama esophagus. The first one is the LES dependent, and the other one is the single peak Jehama swallow, and the other one is the multiple P Jehama swallow. And the multiple P actually is refers to the repetitive contraction pattern in the distal esophagus. In terms of the treatment, in terms of the Chicago classification 4.0 on the hypercontractile esophagus, we try to identify the clinical relevant and clinical irrelevant hypercontractile esophagus. For those patients who have the clinical relevant symptoms, including the chest pain and dysphagia, and these are all that the patient we should focus on, because we need to figure out whether the symptoms is related with the manometry findings. And for those patients with the LES dependent and independent patient, when we compare those patients who have the LES dependent or independent, actually, there is a study published in 2018. They compare those patients who have the hypercontractile esophagus with the LES dependent or independent. Their clinical outcome, their long-term treatment outcome, they're very similar, no matter for the medical treatment or the surgical treatment, including the POM. So actually the phenotype between the LES dependent and the independent, their treatment actually currently, we don't have any evidence to say that we should treat them in different ways. And for those patients who the single P, when we compare the Jehama swallow, the single P and multiple P, we do have some evidence to show that those patients who have the multiple P Jehama esophagus, their symptoms is much more severe than those with only single P. And the therapeutic outcome so far, we don't have any evidence to show that those patients who have the multiple P will have the different outcomes. So currently, when we talk about the treatment of the Jehama esophagus, we just try to figure out whether they have symptom or not, and the symptom is related to the manometry finding or not. I think we still need more evidence to show us whether this kind of phenotype would related to their the treatment. So far we don't have any further difference to try to differentiate their treatment through the phenotype.
Thank you. Was very clear. So you focus on the relation to symptoms that, of course, also in our experience, we think it's very real critical. May I ask, John Clark? Is John?
Oh, sure. Yep. Let me talk about, yeah.
Yeah. Well, the topic for you could be, we like to hear you about the endoflip. Might endoflip be useful for diagnosis or even for treatment?
Yeah, it's a great question. It's a great question. So yes and yes, but probably not yet. When FLIP has been looked at, right now, the main issues that we're seeing with it are the presence of any contractions which are repetitive, which are forward if secondary peristalsis, backwards if spasm. And then we're also looking at a lumen distensibility and diameter. And for jackhammer specifically, the big finding we see with the manometry is hyperperistalsis and high contractions. And right now, the way that FLIP is studied, we really don't get a great look at the force necessarily inside the actual balloon. Now, there are ways to compute that with the software, in particular the version which they have at Northwestern, which is custom made. So there may be a way in the near future to look at the intra-bolus pressure that's being generated. But FLIP is a little bit limited in that we don't really know at this point what's normal. It's not part of our current system to market. And the FLIP catheter itself just has one balloon pressure site. And so sometimes when there's a very hypercontraction, you get this artifact where you end up completely occluding the actual balloon. And so you've got the pressure sensor just on one side of that. So at the moment, FLIP for jackhammer is certainly not as sensitive as the other studies that we have. The one thing that we do see is we'll see at times these very high pressures which completely obliterate the balloon, and we'll see at times these sustained isolated contractions with shortening, but that hasn't necessarily been quantified yet. In terms of spasm, we often can see that with FLIP as more retrograde contractions without necessarily an outflow issue. But again, similar to jackhammer, spasm hasn't been well studied with FLIP at this point. And I think we're still in a point where 5 years from now, it might be very helpful. I think at this point, it's information that's interesting and secondary, but probably doesn't help in terms of the diagnosis, except for with the fact of excluding an achalasia variant that may not have been picked up from the manometry. But I think outside of that, it's probably not there yet. In terms of treatment, if there is an outflow obstruction component with it, then the ESO-FLIP balloon could be used as a large caliber dilation. But if we're looking at more, a classic spasm or hypercontractile peristalsis without an area of outflow or narrowing per se, then FLIP with treatment probably won't be terribly helpful yet. But, check back in 5 years and this might be a different story.
Great, thank you, John. Next question for panelists. I think that George Trefilopoulos there?
Yes, I am, Luigi.
Hi, George.
Buonasera.
Buonasera.
I just woke up.
George, we would like you to delineate if there is an altered neural control and which can be the impact of this on treatment.
Oh my God. Do we have an hour?
No, I think a maestro like you can do this maybe in 5 minutes or less.
So can you please repeat the question? You want me to talk about the evidence of neural control?
Yes. Is there an altered neural control in this disease, and which can be the impact of this altered neural control on the treatment?
I think there is. I don't really have any reference to quote, but definitely there is. I don't think that the muscle that we see, the alterations that were discussed earlier, would change that much. And there is an evolution, I believe, based on what you said at the beginning of this conversation from Van Trappen era, that there's an evolution towards the development of achalasia. There's definitely a thickening of the muscle, and I think it's all dependent on the time of that evolution. In other words, you may have an early neurogenic element, and then you may have a muscle component that may be too late in the process of the disease, that maybe at that point, you will have to really address the muscle specifically. So it all depends, I think, of when you catch the disease. In other words, where do you are at the spectrum of this condition? And as you monitor these patients prospectively without any intervention, you see the alterations. First, you may see disappearance. So in other words, the spasticity is transient and it goes away in 6 months to a year. Sometimes you see evolution towards a more fixed abnormality, maybe at that point you may expect that the muscle is affected. And at that point, it may be too late and you need to do some other steps, such as surgery, for example. So I do believe that there is an early neurologic event, neurogenic event, followed by a muscle alteration. We do see that, as mentioned earlier, in the case of opioids that come and go in their use, and they may cause long-standing disease. But definitely, if you capture the patient using the opioid, you will have definitely a neurogenic component. And also, you do see that, as it was mentioned earlier, in patients with eosinophilic esophagitis. And I think we should not rush to attribute the symptoms to the spasticity that we see with eosinophilic esophagitis, because as you know, all of that may evolve over time. So I'm trying to be as simple in my response to you for the general audience.
You did great, George, and this was we expected from you to do in less than 5 minutes, as we anticipated. You are a maestro, and we know that. And well, I think we'll have time to go back on this topic later on, as the presentation of our case will go on. I have now another question that regards the association between eosinophilic esophagitis and jackhammer. And I guess Roberto Penagini is there. Maybe he's not connected yet.
So this is definitely something which we can see. It's interesting. There was a nice paper that was presented at DDW about 2 years ago, where they looked at patients who had POEMs and found EOs within the muscle layers within a fairly substantial group that had hypercontractility disorder, a lot of whom met criteria specifically for spasm as well as jackhammer. And there is a thought that the eosinophilic infiltration in both the muscle as well as mucosa can affect essentially the neural signaling, which then can lead to higher contractions and impaired feedback from those networks which are there. It's a little bit unclear how much is cause and effect. For instance, if you have an EOE that's a very classic case, a lot of times they can have both hyper and hypo contractions, and there's not necessarily a set EOE associated pattern. But in eosinophilic infiltration that's in an early stage, it does seem a lot of times that can be more of a hypercontractility disorder that then subsequently defines itself later. So I think this is an area that we still are trying to learn more about. But as we get more frequent POEM biopsies and deeper get tissue that's deeper than just the mucosa, I think we'll probably figure this out a little bit more in years to come.
Thank you, John. I'd like to ask now Robert Bechara. Is he with us?
Yep.
Robert, hi.
Yeah. Hello.
Robert, the question is, we would like to ask you your thoughts about the role of opioids in this disease, in this pathophysiological condition. Please.
Okay. So it's you'll get a simple answer from me. I'm a simple endoscopist, so I have a very simplistic view of stuff. But in terms of the opioids in these spastic motility disorders, we know that if you take kind of regular individuals, you give them opioids, and you do motility testing, a fair number of them will develop kind of motility disorders or spastic motility disorders that will resolve after coming off the opioids. But I think you also know that people who are on chronic opioids, it's a little bit different in that they tend to have a picture where they develop EG outflow obstruction, type 3 achalasia, or jackhammer esophagus. And even when you take them off, a fair number of them will resolve in terms of the motility disorder. However, they still end up having a higher proportion of spastic motility than the general population, even when they come off the opioid. So I think clinically, when you encounter these patients who are on chronic opioids and have these spastic motility disorders, it becomes very difficult in sorting out kind of where they fall. Are they the people who are going to resolve after coming off the opioids, and whether or not it's something that's clinically even possible in their case, or the people who, regardless, you're going to treat as a spastic motility disorder and then will respond as kind of a regular motility disorder will respond in terms of treatment. So that's kind of how I approach them clinically anyway. In terms of the pathophysiology, that I usually will kind of defer to my motility specialist in terms of the inhibition of the release of nitric oxide and some of those mechanisms that are induced by opioids. But clinically, that's how I generally approach them.
Thank you, thank you, Robert. Maybe I have a the last question from those topics to Justin Lee. Is Justin Lee with us? I saw him in the chat. Is he here?
Yeah, hi Luigi, I'm here.
Hi,
Yes.
Justin. Hi, Justin. Nice to see you. You are a reflux expert, and I'd like to ask you, how do you see the jackhammer esophagus in the context of GERD, of classic GERD or GERD with maybe atypical symptoms? Is there any clinical picture that can help us to better delineate those patients?
Yeah, I think this is an excellent question. The fact that is because in many of my jackhammers patients, for some reason, they somehow also has symptoms, of course, very similar to reflux, right? Because many of the so-called motility disorders, they tend to have very similar presentation to a reflux disease. So it's very often to misdiagnose GERD. But at the same time, if you were to look at the patient with all these jackhammers, for some reason, at least in my experience, they also have some form of reflux. Possibly, of course, it may be related to the fact that in hypercontractile disorders, it's not a true clearance or peristaltic clearance of sorts, right? Because in reflux, we need to clear the acid, but in someone who has hypercontractile disorders, there's often a difficulty in that sense. But also, I think it's more relevant nowadays that because jackhammers is treated either through myotomy or even POEM, then in these cases, obviously, they may have a reflux after that. So this is also another association, between, although it's indirect association, but this is certainly something that we also observe. Now, I recently did have a patient who turned out to have a jackhammers, but also EGJ outflow obstruction. I think for some reason in those who have LES associated jackhammers, I think their lower esophageal sphincter, the function is somehow disrupted, and that again will predispose the patient to reflux. Although I don't have actual proof to support this, but I think it is certainly something worth studying. Yeah, thank you, Luigi.
Thank you, Justin. Is there anybody from the panel who wants to add anything, something that could be interesting to move forward? Some clarification, further clarification regarding jackhammer esophagus? John, Robert, Dr. Shao?
I guess one of the things that was mentioned earlier about the patients that have eosinophilic infiltrate, particularly in the muscle, and have been treated with POEM. So, and they subsequently get kind of incomplete response just with the POEM, and when they're put on steroids, their symptoms resolve. So it makes me wonder, I'm curious to know what people's practice is when you do POEM for hypercontractile esophagus, if people routinely take biopsies in the muscle. We haven't in my practice, but I know some of our colleagues in Japan, they've now routinely been taking muscle biopsies when they do POEM for hypercontractile esophagus.
That's a very good point. I think we'll come back on this later on. So let me ask now Stefano to proceed with the our case study presentation. Stefano?
Yes, here we are. I'm sharing. Screen here. So Pamela, we'll keep going.
Good afternoon, everybody. We are now talking about a 65-year-old woman who came this year in our outpatient clinic. She suffered from heartburn, occasional dysphagia, and chest pains in 2007, and she referred some recent worsening of her symptoms. As you can see, her comorbidities were atrial fibrillation, COPD, hypertension, and she had a history of a peptic ulcer 15 years ago. She was under PPI therapy with pantoprazole 30 milligrams BCND for the last 5 years, and she had no history of opioid use. Her physical examination was normal. Her BMI was slightly over the normal range, and her bowel habits were normal. Her primary complaints were heartburn and postprandial abdominal bloating, while her secondary symptoms were occasional dysphagia and chest pain. She also complained of recent changes in her dietary habits, and as I said before, regular bowel habits. We usually perform questionnaires for patients regarding reflux, because she was suffering from heartburn and other symptoms related to it. And as you can see in this table, her score was 22, far away from the normal range. Regarding the impaction dysphagia questionnaire, the patient reached a 7, which was slightly more than the normal value, which is 6. And according to the FOSS score for dysphagia, she was a stage 2. So she was she referred to dysphagia requiring significant dietary modification. As first level investigation, patient underwent an upper gastrointestinal endoscopy, which showed a vigorous contraction of the esophagus, no evident stenosis, a patent cardia, and a small sliding hernia on maximal air insufflation. No sign of esophagitis were seen, and biopsies were negative for Barrett's or eosinophilic esophagitis. She underwent then a barium swallow study in 2 different positions. In the upright position, the tertiary peristalsis was reported by the radiologist, while in the supine position, a 3 centimeter sliding hernia was seen. So, Stefano will continue with the second level investigations.
Yes, of course. She underwent a high resolution manometry. So first, as underlined in the Chicago classification 4.0, we did it in an upright position. So Chicago classification says that you can choose your position. We prefer to do it upright or semi-recumbent, and then do it the secondary position supine, because it's more comfortable for the patient. So this is one of the 10 swallows, and these are the data and the report for the HRM. It shows an IRP of 17.2 and 90%, so slightly over the threshold for edge junction outlet obstruction. A number 9 out of 10 swallows with DCI more than 8,000, with a median DCI of 21,000. The intrabolus pressure was higher in 60% of the swallows, and unfortunately, the multiple repeated swallows and the rapid drink challenge couldn't be done by the patients. She failed both of them. So according to Chicago classification 3.0, this patient would have been classified as edge junction outflow obstruction, but of course we couldn't have ignored the jackhammer esophagus, so the 9 swallows with DCI more than 8,000. Unfortunately, we have the Chicago classification 4.0 that came in our help, and because there was a redefinition of many parameters, and between them the edge junction outflow obstruction, because now, as you can see here in this table, the diagnosis is more strict. So you need more parameters to define a clinical significant edge junction outflow obstruction. You need in supine position an IRP more than 15 millimeter of mercury, and in upright position more than 12, the intrabolus pressure higher in more than 20 swallows, and then you need clinical relevant symptoms and other investigations supporting the obstruction. So in supine position, this is one of the 5 swallows that were taken in the supine position, and the IRP were surprisingly little below the normal limit. All the swallows were hypercontractile, and the intrabolus pressure was higher in just one of the 5 swallows. So it was 20%, which is the borderline value. So we, coming back to the previous slide, we just have clinical relevant symptoms. We don't have a real and a strong evidence of edge junction outflow obstruction, and we also don't have supporting investigation supporting the edge junction outflow obstruction. So to take a summary of this clinical case, we have a patient with the GERD versus mild hypercontractility symptoms. So both these types of symptoms were present in the patient, and the hypercontractility symptoms were not affecting heavily her quality of life. We have an unclear diagnosis of edge junction outflow obstruction, and we have a severe hypercontractile pattern on HRM. So what to do next? I will hand it over Professor Bonavina for the next round of panel discussion.
Thank you, Stefano. So we have, of course, many questions left, and we are still at the beginning of our case study presentation. But let me now ask Dr. Inglian Xiao and Dr. Javali, maybe is here with us now. How much should we rely on those symptoms? What are the clinically relevant symptoms? What is the role of GERD and other questionnaires, Foregut questionnaires in clinical practice? Dr. Xiao?
Yes, Guli. Thank you for the question. Actually, in the Chicago classification 4.0, we do focus on those clinical relevant symptoms a lot, because for those patients who have the chest pain and dysphagia, we think it is clinical relevant, because according to the previous publication, those patients who have the, for example, the EGJ outflow obstruction or jackhammer esophagus, and their therapeutic, when we try to analyze their symptom and therapeutic outcome for those patients who have the dysphagia and chest pain, actually these symptoms are more related to the manometry finding and their symptom outcome. So, so in the updated classification, we say that we have to analyze those patients' symptoms. If they do have the chest pain or dysphagia, they are more. It is more possible for them to have the clinical relevant, for example, EGJ alpha obstruction. In terms of this patient, actually the patient has a GERD symptom. Also, the patient have the dysphagia. So this patient, actually, I would recommend this patient to have the pH monitoring, because according to our experience and the publication, about 20% of the patient, the GERD patient, with the high hypercontractile esophagus, they might have a positive pH monitoring. So actually the etiological factors is related to GERD. And also some patient, according to our previous discussion, some patient might have the OPN or the esophageal eosinophil esophagitis, but we have already ruled out these two etiological factors. So I think the pH monitoring is is necessary. And also the patient has already done the time balance and the time balance swallow, and I don't have any experience on the end of leach to the JHAMA esophagus or the outflow obstruction, because we don't have this technique currently. So I'm not sure in this point whether the patient should have the end of leaf first or the pH monitoring first. But I do think the pH monitoring is very necessary to rule out the etiological factor of reflux.
Would you think that a Bravo pH monitoring is contraindicated in those patients with a suspected spastic disorder, just by stimulation of the mucosa, or not? Or
No,
we can do either a catheter pH or Bravo capsule?
In my center, we usually do the catheter base. I don't think it is a contraindication. Actually, we do find some patients who have the distal spasm and JHAMA esophagus. They are related to GERD.
Okay.
But in some patients, actually, even we have some limited experience, even the patient have the positive pH monitoring. If we give them PPI, the symptom might not relieve. So in this case, so in this condition, maybe the symptom might not be due to the reflux. So if you give the patient with PPI, the patient do not have symptom relief, maybe this is not due to the reflux. Yeah, we have a very little limited experience on this.
Okay, thanks. Next question, I'd like to ask John Clark and maybe somebody else from the panel. Should we consider further diagnostic assessment after HRM, like we just said, the pH study as suggested by Dr. Xiao, but also endoscopic ultrasonography? I think that it was already mentioned before by George. And what about endoflip again?
So I would confer or concur with Dr. Zhao's prior talk. I think the main symptom appears to be heartburn and reflux at present. We've got a hernia that's present there. It looks like with the manometry, if there is a component of outflow obstruction, it appears to be linked with the hernia itself and not the LES looking at it. So my sense would be that going after the reflux piece would make sense. It seems like there is dysphagia, but that's less problematic based on what symptoms she's reporting as well as the questionnaires. In terms of catheter-based versus wireless, I think it's dealer's choice and what's available in that scenario. The one caveat being that with the wireless probes, in these spastic cases where there's hypercontractility, a lot of times that spasm will dislodge the probe, so that you may not get the 96 hours of data. You may only get 24 or 48, but you'll generally get at least 24 hours. So I think it comes down to what you have there. And then if it does look like there is GERD that's present, I'd probably go after that in terms of therapy, but with the caveat, as was just mentioned, that treating the GERD may not make things better with the motility. But at least in hearing the first part of this, it sounds like reflux is more of the dominant symptom, and her symptoms of dysphagia at this point are very mild. So if her reflux symptoms get better, and it's just the mild swallowing issues, and you're comfortable, you're not missing something like achalasia or cancer, then I wouldn't necessarily feel compelled to be too aggressive with that. Now, I'll say that sometimes, when you have a hammer, everything's a nail. So we often will do end-of-flip just because we're doing endoscopy and we're there anyway, and the question has been asked. And so it wouldn't be unreasonable to look at that. I think your main purpose would be looking to see if there's any subtle narrowing, looking to verify the outflow obstruction is not a factor, and checking to make sure you're not missing a variant of achalasia. But I think in this situation, your money is probably worth the pH studies instead.
Luigi, can I make a comment, please?
Yes, of course.
To cover the issue of reflux-related hypercontractility, I usually do something which is very practical, which is if a motility shows in a symptomatic patient, I don't tend to study asymptomatic patients, shows hypercontractility, I usually then, if there is a question of reflux, I treat them empirically with a PPI, and then repeat the manometry sometime between 1 and 2 months later, particularly if I don't see a good response. If at that point the motility becomes normal, then I dissociate the two and I go down the path of PPI or surgery or what have you. So I think that's a practical tool for somebody who does not like to repeat tests. Our patients do not want to have repeat tests, but I do it sometimes to clarify the role of the hypercontractility and reflux playing a concert together.
Excellent. Thank you. Any other question or comment from the panel or from our larger audience? I see that Adriana Lazarescu is now with us.
Oh, good morning.
Make any comment?
So I agree with what's come before. I think, forgive me if I had Wi-Fi problems. I don't know how much was spoken about a barium study. I think the barium can be very helpful both in outlining the anatomy. Sometimes we think endoscopically we get a better sense than we really do, and especially with the hernia and the angle at the G junction. But also with respect to bolus transit, I'm a big fan of a timed barium swallow with either marshmallows or the barium capsule in order to see if there is any holdup in wear, because I'm sure this was mentioned, EGG outflow obstruction on manometry can mean something or cannot mean something. So to me, that's been very helpful in these situations where there is almost opposing type symptoms. Sorry, I missed this part. Okay, tertiary peristalsis and hernia. Okay, but I was just going to say this is very helpful to me in patients with these types of combined symptoms.
Are you a surgeon, Adriana? Because we share everything. I know that barium swallow is even in our center. Many gastroenterologists and even the radiologists consider it an obsolete test. We don't think so. We think it's a first-line investigation. Maybe not a first line, but it's a really important investigation for decision-making and to get better oriented in depth in the disease in our patients.
I'm a gastroenterologist,
Okay.
but I would, do you find that the expertise in interpreting these tests is declining in radiology? Because
Absolutely.
that's what we're finding, which is a problem.
The new generation of radiologists are unable to do classic barium swallows. They are very good in TC, NMR, or whatever, but almost forgot, actually didn't learn how to do, for instance, a contrast barium enema, which is also very useful. Luigi, may I ask a question?
Yes.
I agree with George about the empiric PPI therapy, but I would like to ask him and tell that if we do it, we should use a very full dose, that is at least a full dose twice daily. Otherwise, the empiric trial will be almost inevitably unsuccessful. What do you think, George?
Carmelo, I was referring to a full double PPI dose,
Oh, that's
as you said. And that is actually my effort to try to eliminate the role of reflux. And I hope at that point, and sometimes I accomplish that I normalize the high resolution manometric findings. And that's the two together much better.
Absolutely, I fully agree. I mean, I absolutely fully agree.
Yeah.
I would like to ask to Robert Bechara a question. We won't probably treat this patient with POEM, but would you do the muscle biopsy as you suggested before in this patient, also even if the mucosal biopsies were negative for eosinophilic esophagitis? Do you think there is?
So I think routinely, as I said, we generally don't. But in this particular case, if you were considering it, it wouldn't be unreasonable. Initially, I'd be a bit reluctant to kind of consider POEM in this patient because the dysphagia and chest pain, as everyone mentioned already, are kind of the secondary symptoms. And the primary symptoms that are most troubling appear to be kind of the bloating and the reflux symptoms. So I'm generally very reluctant to offer kind of a permanent treatment such as POEM when the symptoms and the manometry in terms of the correlation may not be great. I would try kind of anything reversible initially, such as, again, trying the trial of PPI, whether you try, in this particular case, calcium channel blockers or something that's reversible to see if you can get an incremental benefit before jumping down and doing something that's permanent when we don't really know if it's going to make anything better per se in terms of her symptoms and potentially make things worse for her clinically in terms of reflux.
Thank you.
Okay, I think that we can move on with our clinical case, Stefano.
Yes, so we have therapeutic option. So here we are. So in Chicago classification 4.0 is pointing out that in these hypercontractile disorders, we should provide caution approach. So we shouldn't give endoscopic or surgical treatment as a first option, but we should start with conservative medical therapy before trying something more. And I think is really a reasonable choice. So as the current literature suggests, medical management consists of antispastic drugs, nitrates, nifedipine, or other calcium channel blockers, or sildenafil. So I would ask now one of our panelists, maybe Adriana or George, if you could tell us something about your experience on medical management. How do you usually treat these patients, and which will be your first choice?
So for me, the middle two are the ones I've used most often. I haven't had much success with hyoscyamin or any of the other antispastic drugs. And in Canada, we don't have coverage for sildenafil for this sort of indication. I would use a nitrate if the patient has quite intermittent symptoms, so they can use a spray PRN under the tongue. It's worked sometimes, but it's quite limited by the side effect of headaches. I've had a lot more success with calcium channel blockers, and I've tried both diltiazem and nifedipine. I particularly like diltiazem short acting because I start it before meals and I very slowly titrate up to either effect or side effects, if you like, the hypotension, which can affect some patients. But I've actually had quite a bit of success with that. And what I would often do is once I get to a dose that works, and then I try to consolidate it on a long acting so that they're not taking pills all the time. But I've had a reasonably good experience with that. Usually these are older patients that can't have something else, the more definitive, like a POEM, if it is a primary esophageal motility disorder. But that's been my experience. I'm curious to hear from the panel about other people's choices.
Yes, Luigi. I fully agree with Adriana. We should know that all these drugs have a formal indication. So in any case, any drug we use will be off-label use. So this could be risky, but usually the drugs are a short-term treatment because they are a bridge between the diagnosis and the surgical or endoscopic therapy. So their use is really for a short time period. My preference goes to nifedipine sublingual. We do have a sublingual formulation, which is extremely good and could be chew and split after getting an effect, avoiding the full absorption of the entire formulation and reducing the risk of hypotension that Adriana mentioned. Of course, if the patient is hypertensive, that's even better because you can kill two birds with one single stone, let's say.
My therapy of choice with this actually is peppermint, and it's based on a paper that Castell did a couple years back. But the nice thing about that is that it's reasonably short acting. Safety is excellent. I find a lot of times these people have other medical issues, and sometimes calcium channels or such can have other systemic effects. Peppermint's really very well tolerated. It's also in the drugstore, and so patients can get the Altoid mints, chew it, generate liquid, swallow that, and sometimes they'll like carrying that more so than carrying pills. There's certainly not long-term benefit with it necessarily, and I completely agree. This is really a bridge towards something else. I think the other thing, just to mention is all of these therapies which do lessen the muscle pressure are going to make the reflux worse. So if this is really a reflux driven phenomenon, that's something which you'll have to factor in. I think in this particular patient, since the reflux symptoms appear more profound than swallowing issues, I would probably still focus upon the GERD first and then keep this as a secondary option. We've had some success using sildenafil here, but it's a bit of a challenge with insurance. It always takes doing letters of medical necessity. And so I find that while we've done it in a few patients, it's really a last resort option for us, just because it takes a fair amount of effort on our part to get going.
Thank you, John. So if anybody has anything to add, we can keep going the discussion on medical measurement. Otherwise, we will start to discuss one of the main points of the management, which will be the endoscopic treatment. So we have here, we have basically three options. So we have Botox, we have pneumatic dilation, and we have POEM. According to the literature, we have a lot of reports with the use of Botox in hypercontractile disorders. Resume of the literature shows that the clinical response rate is really variable, is between 33 to 72%, but all of them agree that the duration of symptom relief is really limited. So it's about 6 months. So after 6 months, the patient has to redo a Botox injection or try something else. And according to the ESG guidelines published last year, we don't have strong evidence supporting its use. And anybody has experience with Botox for hypercontractile disorders?
Yeah, I mean, we've tried that, typically as our first line, with the idea being that, if they do get better, then it buys time first, and then it supports being more aggressive. Safety is pretty good. So it is something that we've often done here. I can't say we've had dramatic success across the board with it, and but it, it's pretty safe and it's available, and so that's often the first line that we've done here.
Thank you.
Let me ask Stefano, what's said in the literature regarding the technique for Botox injection? Were directed to the LES or to the esophageal body with multi-level injection?
Is a multi-level, so it's a B-level. So it's at the LES and 7 to 10 centimeters above the LES on 4 quadrants. So yeah, also the guideline says that there is no strong evidence, but if we want to try it, we have to do it this way, because the better results are granted with this technique.
Okay, thanks.
Okay, so
can I interrupt you just a second, because we have a question from the audience, and it's Dr. Oscar Paetz. The question is if there is any relation between achalasia and esophageal dysbiosis. I think this is a very intriguing question, and maybe we have some experts here to answer. I don't have an answer for that personally, but maybe John. I see John, and maybe John can give us some.
Yeah, I don't have a great answer for that as well. I know there are some people who are doing research looking at the microbiome within the esophagus specifically, and there have been differences shown in EOE and GERD, plus also in Barrett's. And I couldn't tell you exactly which species are more common within those conditions specifically, but there have been published differences with them. I don't know if achalasia has been looked at per se, and I think the big question with all of these are that while there are differences within certain disease states, it's a little bit unclear if this is cause or else effect, and I think that's something we'll probably learn more in the next couple of years. But it is something that's being looked at, but I'm not aware of literature in achalasia or in hypercontractility per se, just in GERD, Barrett's, and EOE at this point.
Yeah, Luigi, the problem is that every time you have a stasis in every region of the tube, let's say, of the gastrointestinal tract, you will get dysbiosis for sure. But dysbiosis, which was in the past considered just an increase in the total number of bacteria, generally 10 to 5 colonic forming units per milliliter of fluid, is now considered more from a qualitative than a quantitative point of view. That is, it is more dangerous having a more gram-negative colonic type bacteria than having a more gram-positive oral flora type bacteria. And this is because the increase in mucosal permeability, which is the trigger, or if you want, the primum movens of any pathophysiology effect, is increased only when colonic type bacteria go up into the stomach and the esophagus. But I remember there should be a very, very recent paper from Japan showing that in achalasia, the esophageal microbiota is deeply changed in an inflammatory pathway, and this is reversed by POEM, showing that maybe, I am saying maybe, a cause-relation effect could be the case.
Very interesting, Carmelo. Should we move on, Stefano?
Yeah, let's keep going. So we don't have real evidence supporting indication for pneumatic dilation, and we can move to the main topic because we have great endoscopists in the panel, and which is POEM. So POEM, as you can see in these two recent reviews, has a pretty high success rate. So in the latest review that we found in the literature, considering 210 patients, the cumulative success rate was 89%. But in this one, the jackhammer success rate was 72%. So was pretty high, pretty good results. Of course, there are no comparative studies, and all studies are case series, so there are no randomized trials or other high evidence studies. So ESGS still recommends being cautious in treating spastic disorders other than achalasia with POEM. Now, I would like to ask Robert Bechara, given your experience, if there are technical aspects of POEM that we have to take into account when we treat these disorders. Of course, maybe our patient has not has not dysphagia or chest pain, or has a mild hypercontractility disorder symptoms. But if you have to treat the hypercontractility disorder with POEM, would you do anterior versus posteriors? Does it make any difference? Would you treat the whole muscle layer or just the circular layer? Or would you stent the myotomy on the LES, or you will preserve the LES? So I would like to ask you to comment on that.
Sure. So good questions. So in terms of the technical aspects of it for these hypercontractility disorders, so again, assuming that clinically we've decided this is definitely something that will likely help the patient. So I take into consideration the manometry. So I'll have a look at the manometry as well, including with my motility colleague, and then their endoscopy. So things on their endoscopy to take into consideration is just where I see the most proximal extent of the abnormal contractions are. And then I'll also take into consideration chest pain. Do they have a lot of chest pain or not so much chest pain? So in the end, what I'm trying to do is basically get to the most proximal extent of the abnormal contractions that are causing their symptoms. And in terms of anterior versus posterior, there's maybe a trend towards more reflux with posterior than there is with anterior. My practice is still posterior, and the reason being is if you avoid the sling muscle, if you do the posterior approach in the 5 o'clock position, and you keep your tunnel straight and go down, you'll usually encounter the sling muscle just to the left. And if you ensure that you spare that, and then you do a limited myotomy on the LES, the risk of reflux doesn't appear to be more. So when you look at sparing the sling versus not sparing the sling muscle on the posterior approach, when it's identified and spared, the overall risk of reflux appears to be low in some of the smaller kind of comparative retrospective studies. And that's generally my approach. And our risk of reflux is not particularly high overall. It's about 20 to 30% using this technique in the posterior. In terms of cutting the LES in the hypercontractile esophagus, so there's a lot of kind of disagreement on this. Some people say cut it, some people say don't. I now kind of generally gone to cutting the LES for the hypercontractile esophagus, but again, doing probably about 1.5 centimeters or so onto the LES. The reason being is the possibility that afterwards there's been some patients that are hypercontractile and years later will become achalasia. And in those circumstances, you may then have to repeat a procedure if you avoid the LES. The other reason I think for including the LES is after doing a long myotomy, I think there's also a possibility of developing ineffective esophageal motility. And if, again, with the LES being cut, I think it will decrease the possibility of them having some symptoms from kind of the ineffective motility with the LES spared. And again, that particular part's not really based on evidence, but there are definitely patients who have, say, jackhammer esophagus that subsequently evolved to type 3 achalasia. So that would be the main reason, in my opinion, for including the LES. But I know there's a lot of disagreement on that. Some people generally spare it regardless if it's in jackhammer esophagus. So that's kind of been my practice for jackhammer.
Thank you. Yeah, we kind of
Just a second, Stefan. Can you? I think I see we have the honor to have among the audience our friend Ivan Ceconello. He's asking what's about reflux.
Yeah. So in terms of reflux after POEM, again, it's a very controversial topic in terms of how it's defined as well. So you'll see studies that say, oh, after POEM, the risk of reflux is 55% or 59% because of pH. And other studies, you'll see much lower incidences depending on what they use as the definition. So I think one is using a uniform definition across the studies, which is generally not done. They all use varying definitions. I think based on, for example, the Lyon consensus, if you see the recent paper in the New England Journal, the RCT done, and initially they saw there was an increased incidence of reflux in POEM as compared to Heller-Dorr. But when they looked back and did a post hoc analysis and used the Lyon consensus, the risk of reflux was no different between POEM and Heller. So I think one of the issues is the uniform definition of reflux. I personally don't think it's much higher than Heller-Dorr, and our experience has been 20 to 30% based on the Lyon consensus. So I don't think, at least in my experience, it's been as big an issue as sometimes it's made to be, but obviously I'm a bit biased as an endoscopist.
Robert, let me ask you, and from your experience and from the literature worldwide, you know, I saw in the past papers from Inoue, who actually devised the POEM. He was supporting the longitudinal muscle preservation. Maybe you said something
Yes.
before, maybe I
Yeah,
missed.
sorry.
Is it a factor fantasy? Is it really possible to preserve the longitudinal layer?
So I think in
This
terms of
this could reduce the incidence of reflux theoretically.
theoretically, you're right. But I think it's been looked at in studies in terms of full thickness versus selective, and there's really no difference in terms of reflux. They're not great studies, but they have looked at it. The other thing is when you do a selective myotomy, even when you do a selective myotomy, sometimes the longitudinal fibers still split just from the scope passing, and you end up with a full thickness defect anyway. So I think, in my opinion, and again with Dr. Inoue, when we were chatting about it, it's more of a safety issue. So if you basically are aiming to do a selective myotomy, you're generally aiming to keep the longitudinal spared, and you're not really aiming to cut essentially into the mediastinum and peritoneum. Sometimes, though, you still end up cutting the longitudinal fibers. Sometimes you still end up with a full thickness resection. But if you're aiming from the beginning to do a full thickness incision, you still sometimes will go a bit further than what you expect. And you're going to cut some mediastinal vessels more often, peritoneal vessels more often. But clinically, in terms of reflux, I don't think it makes a difference, but I do think it makes a difference overall in terms of safety, encountering bleeding that's unexpected. For example, if there is that case report of pneumopericardium some time ago in endoscopy, and they were doing an anterior approach, and I think they were doing full thickness. So it's not that you intend to cut the pericardium, but if you're intending on doing a full thickness dissection of the muscle, there are going to be times where you go a bit deeper than expected. So that's why I choose to always try to selectively do a circular myotomy.
Yes, we have another concern now from the audience. Jenny Myers is asking, what's about long-term reflux?
Yeah. So I think the long-term reflux, we probably, we have some 10-year data out from Inoue's group, but we don't have 10-year data really on reflux. So in terms of how it evolves, so I don't think we know very well long-term how things are going to evolve with reflux. We have kind of midterm 4 or 5 year data where, again, there's not much of a difference, I think, in terms of initially. If anything, I think over time it may decrease, probably due to some fibrosis at the GE junction and it being somewhat tightened a little bit, versus if you check, say, 3 months post-POEM in terms of doing your 24-hour pH and endoscopy, then checking, a year, 2 years down the line, it may be slightly different or slightly less, but I don't think there's good evidence now to tell us long-term exactly what happens with reflux.
Okay. Stefano?
Yeah, Jenny Myers just wrote again, if you want to.
Yes. Question about PPI or intermittent endoscopy in the surveillance.
So in terms of the surveillance, that's another topic in terms of whether you survey some of these people because of the risk of squamous cancer or not. Again, that's a bit controversial, whether you do it every 1 to 3 years. My practice is generally to survey them. The interval depends on really the degree of stasis they still have. So if they have advanced sigmoid achalasia and they're younger, I still tend to survey them pretty early. And we have found a few squamous cancers in them. So if that's the case, what I'll often do is before the endoscopy, I'll stop their PPI for at least 2 weeks, and then I'll do the endoscopy. And at the time of the endoscopy, I can then see, do they have esophagitis, and see what their symptoms are like in terms of having reflux symptoms. And then depending, we may consider discontinuing their PPI. I do their 24-hour pH roughly 6 months after. And again, stopping the PPI about 2 weeks before that to be able to evaluate the esophagitis. But in terms of long-term, I'll usually get them to stop it roughly 2 weeks before their surveillance endoscopy and reassess the reflux symptoms and the need for PPI or potentially discontinuing it.
We're pretty similar at our site as well. We end up doing a manometry flip plus endoscopy with a wireless probe off meds 12 weeks after POEM. And then based on what that shows, we end up adjusting at that point. If they have a fair amount of acid or else esophagitis at that point, we do keep things going with a PPI. But if it looks like there's no esophagitis and you know things look fine with acid, generally we don't at that point. And then you know typically with surveillance, we're going back and looking with endoscopy every 2 or 3 years. We typically don't do a wireless probe in those follow-up studies unless there's something that really jumps out then.
Thank you. So let's move on with the laparoscopic surgical approach. So it might be done in Heller myotomy plus door fundoplication or toupet fundoplication. Of course, this choice provides us a shorter myotomy as compared with POEM, but better reflux control, because not only we could do a door fundoplication or fundoplication to preserve the distal esophagus from reflux, but also, sorry, here, a crural repair, which is of paramount importance to prevent reflux, as demonstrated by this report, by this study by Louis. And so, what do you think about surgical procedures? Should it have more space? Should we prefer endoscopic over surgical procedures? Any comments on that? Does anybody have experience on surgical treatment of this disease?
Well, traditionally, I think that traditionally the Heller myotomy approach has been criticized just because there was not enough, although we can go up to and what we do, we go up to 6 to 7 centimeters above the crura. Actually, you can have some persistent dysmotility above that level. So that's the reason why POEM could be more attractive for treating spastic esophageal disorders. But I don't think there is enough evidence, and the strength of recommendation is quite low. And I don't know if my friend Penagini is with us now, but I think we share an interesting case of a patient with a very long-standing diagnosis of diffuse esophageal spasm, or otherwise interpreted as a spastic disorder anyway, who had Heller myotomy first, a second extension of the Heller myotomy through the chest, and he ended up with an esophagectomy. And myself and Roberto Penagini, where this was not treated by us, came as a consultation from elsewhere, and we were surprised how in this patient whose primary symptom was actually chest pain, was not relieved even after esophagectomy. So I think you know, there is not enough evidence to draw any significant conclusion.
Thank you. And yeah, and the last approach that, I mean, there is no evidence for this neither, but there could be an idea or an option in for further studies or for further treatment, will be POEM and then a combined endoscopic laparoscopic approach. So POEM either with or without crural repair and door fundoplications, if there is a pH study positive or there are heavy symptoms reflux. So Professor Bonavina, would you like to comment on that? Or
Well, I think this could be theoretically an interesting approach. I don't know if there is any evidence. Probably there are some case reports, maybe. I would like to ask also the audience. Actually, this, well, our patient did not fit the criteria for having, because the predominant symptom is reflux. You are following her in the outpatient clinic. I don't know if there is any recent evidence of worsening of symptoms, but in an ideal patient with a spastic disorder like this jackhammer and associated hiatal hernia, this could be a potential treatment, provided that there is evidence of reflux, and but at this point I would like to ask John, Robert, what do you think about? Is it fact or fantasy?
Yeah, it's a tough call. This is a challenging case. You know, I think if treating the reflux alone has not improved any of the symptoms, you could certainly make a case to do a combination therapy. And I know there's been a lot of interest in doing things like combined TIF and POEM as well, and reducing the hernia. But you know, I do think reducing the hernia and doing POEM at the same time would be a very reasonable approach if, you know, dysphagia is significant enough to warrant it, and if treating the reflux alone in isolation has not improved things.
Well, let me ask Robert. Robert, what, from a technical standpoint, could be, do you have any experience maybe already, could be easier to do a POEM combined with a laparoscopic approach? How do you feel if the patient has a hiatal hernia? You may have some trouble in doing the POEM, and it could be useful to have a surgeon that in combination reduce the esophagus in the abdomen and let you do the POEM or not?
Yeah, so I think from a technical standpoint, it may make it a little bit easier. So we've had a couple of patients who have small hernias, and we've discussed the increased risk of reflux with them and whether or not they'd want to either undergo a staged approach where we do POEM, see how they do in terms of reflux if it's really uncontrolled, then having surgery, or basically doing a joint procedure. And so far, it's only been, again, a handful. We've just had a couple. We've done it solely just the POEM approach, and just they've ended up being on BID PPI, but have done reasonably well on that. But in terms of people with large hernias, if it's not a hypercontractile esophagus or say type 3 achalasia, I think they're probably better served if it's type 1, type 2 with a large hernia, probably better served surgically. But if it's something like this where they have a type 3 or a hypercontractile esophagus and we've decided on treatment, I think a joint approach would probably make things technically easier in terms of the esophagus being straightened, and the outcome, I think, obviously would be better for the patient. But we have no experience thus far in this.
Okay. Any other comments? What did you do, Stefano, on this patient?
We were
presentation finished. We are waiting for suggestions from the panel and the audience.
Yes.
Tough decision.
Tough decision, yes. So we took the opportunity to discuss this borderline patient with all these panelists and personalities of esophagology. So now we have more ideas for these patients. And so we can move to the conclusion, maybe, to the last slide of this presentation. So what we learned today, I think, is that core diagnosis is crucial, and we have to use all we have in our armamentarium to better define the patient in terms of symptoms and objective tests. Medical management is usually ineffective on the long term, and they're also off-label drugs. So if we want to treat the patient and the patient is really symptomatic, we have to think of something else. And as the last discussion had pointed out, POEM with concomitant chlorella paste might be an option. So we should explore this option more in the future to give evidence that now we surely don't have. So thank you for the attention. I would like to ask if there are questions or further comments.
Stefano and Luigi, I have a couple of questions to ask you all. The first has to do with the localization of the poem. In other words, is it useful for an endoscopist to mark, to have marked the area of the abnormalities? In other words, if you look at the motility on a high resolution manometry, you start seeing changes at a given level of the esophagus, and to what degree that, compared to, let's say, the location of the GE junction, would be useful to the endoscopist who will do the poem. Because obviously, you don't have to do an extensive myotomy if the problem is localized. That's the first question. The second question has to do with, is there anything that we need to know about Candida esophagitis in these patients? Do we have to postpone the poem if the patient has a candidiasis? Do we have to repeat after the course of therapy? Is there a reason for us to postpone any kind of intervention in the context of someone who has esophageal candidiasis? Because that happens quite frequently in this population.
Well, regarding the last question, my personal opinion is that all those patients should be preventively treated with antifungal medication before proceeding with any kind of procedure. Regarding the first comment, maybe there is somebody more expert than I am, like maybe Robert or anybody else.
In terms of the usefulness, I think it is very useful for these patients, again, who have type 3 achalasia in particular, in terms of looking at their manometry and seeing how far up the spastic segment goes. Because it's not uncommon that some of the patients we get, say, post-Heller, who have a partial response to treatment, and they had their manometry before high-resolution manometry, and you repeat it, and they have a proximal spastic segment above where they did the Heller myotomy. So I think when we do POEM, and I have the high-resolution manometry, they have type 3 achalasia, I can get an estimate roughly how far up to go. And then endoscopically, you usually sit for a few minutes just watching the esophagus and see where the spastic contractions go, in addition to the barium esophagram. So take all those pieces of information together and try to tailor it as best as possible to the patient. I think not one of them is a perfect piece of information, and it's, you know, never perfect, but each one of you gives a little bit, each one of them gives you a little bit more information to hopefully better tailor where to do the myotomy from, to kind of best treat the abnormal segment. And that's been my practice. I try to use each piece of information and then kind of tailor it.
One more question, Luigi, if I may. What do we do with patients who persist having mostly chest pain? We have done whatever we have done poem, door, fundoplication, etc., and they're left with chest pain. Dysphagia usually gets better, but the chest pain sometimes becomes a thorny issue. Is there anybody having any ideas of how to manage that patient population?
Well, as I said before, we shared a patient with Roberto Penagini. This patient was treated for predominant chest pain. He ended up having an esophagectomy, and even the esophagectomy did not relieve the chest pain. So I think that for those patients, just maybe lowering we should work on the threshold for pain, maybe with citalopram or drugs like that to increase the threshold for pain. I don't think there is any other option. This patient I just referred to is still fighting, and is still complaining of those incredible accessional episodes of excruciating chest pain.
Luigi,
Sorry, go ahead.
The tricyclic antidepressants are much better than citalopram or SSRIs. And a drug which has been used in the past for non-cardiac chest pain, very successful, has been trazodone, which is an atypical antidepressant, able to really work as, let's say, a visceral analgesic, lowering, as you said, the pain threshold. But we have to emphasize that the recalcitrant chest pain need always, especially in the aged people, not necessarily old people, needs a cardiac re-evaluation, which has been done at the beginning, I know, but it should be redone, because we know for many years that reflux, as the perfusion of the esophagus and so on, can reduce the vascular reactivity and reduce also the efflux of oxygen to the heart. So there could be what is called microvascular angina, which is often overlooked because it does not appear to the classic stress test or scintigraphy or whatever. So before taking away the esophagus, I would say nothing against your patients, of course, but I would reevaluate also the heart and in some way even the lung, because we should remember that we have 3 key organs in the chest, and chest pain can be due to dysfunction of all of the 3.
Well, very good point, Carmelo. I agree 100%. Any other comment, question?
Yeah, so just another point. I think that's important with these patients who have who have chest pain as part of their motility disorder. It's often very difficult to distinguish sometimes what's motility driven and what's maybe esophageal hypersensitivity. So I think it's important when you're dealing with the patient before as well to kind of set expectations. So I'll often tell them as well that if your pain is due to the esophageal spasms or the esophageal muscular abnormality, after POEM, this will improve. But if it's due to hypersensitivity, it will not improve. And sometimes it's very difficult to tell beforehand how much it's due to hypersensitivity and how much is due to esophageal spasm or the motility disorder. So I think if the patient knows as well beforehand that this is the possibility, it makes it a bit easier for them down the line to accept if after the POEM, as you said, the dysphagia improves, regurgitation improves, but they still have this hypersensitivity chest pain. And then, they're a bit more accepting of it. And then going down the gamut of trying TCAs is usually my first line as well, to see if that helps. But I think the setting the expectations helps a lot, managing them down the line as well.
So that's great. I think no other I don't see any other questions. So let me first of all say thank you to Professor Julie for, and I'm always grateful to him for his incredible energies he puts in the organization of those meetings, and it's really incredible. Thank you again, and thanks again for inviting us to contribute with the case presentation, and I look forward to seeing the monthly events that OESO and Professor Julie and George Triadopoulos organized for us. Professor Julie, the last words for you.
Well, thank you, Luigi, for your words. And what I think is that it was, again, a discussion of considerable educational interest, with all the disciplines brought together, with a broad overview, as you did, for the technologies currently available for the diagnosis and the therapeutic strategies that could be envisaged. And I should add that the impeccable organization carried out by Frederick allowed for the smooth running of this discussion, which is really somewhat amazing. And the discussion went on with the team of Milan and with the participants, with an exchange of many people in the audience. It was very numerous today, and I think all should be thanked. Can I say that the OESO-SEMPIRE network continues to grow with the upcoming addition of other pilot centers to our network, in Mainz with Professor Griminger, in Kuala Lumpur with Professor Justin Lee, and hopefully with Professor Lingliang Chao as well, China, where the network already includes 6 centers in various cities of China: Beijing, Shanghai, Fuzhou, Shenzhen, Chengdu, and Shenyang. I think that the particular educational quality offered by what we call now the virtual global interactive staff meeting, when they are at the scientific level that had the demonstration today, reinforces our view that this is a new initiative, which in this form represents a real instrument for multidisciplinary education. And we will await the decisions of our board for the resumption of our traditional congresses, but we will continue to develop what Luigi, you call the monthly educational discussion, which is a tool that we will strongly support with enthusiasm. The next clinical case will be discussed from São Paulo. I saw Ivan Ceconello there today. I say hello to him. And this will be organized by our friend Bruno Silberstein with a panel that we will have to organize on his side. Thank you to everyone for attending this session, and all the details for the next one will be given on our website shortly. Thank you.